All right, let's begin. Today, we're simulating a classic general surgery viva station, one that every candidate needs to master, the pigmented lesion.
Candidate, your next station. A 45-year-old patient presents with a changing mole on their back. How do you proceed?
Okay, thank you. I'll start, as always, with a thorough history and a focused physical examination. My goal here is to build a solid differential diagnosis. Obviously, malignant melanoma is at the top of my list, but I'm also considering other possibilities like a benign nevus, seborrheic keratosis, or even a pigmented basal cell carcinoma.
So, for the history of the lesion itself, I'd ask about any associated symptoms. Things like itching, bleeding, or pain. These are red flags for inflammation or ulceration. And most importantly, since the patient said it's changing, I really want to dig into that. How has it changed? In size, shape, color? How quickly has this happened? That evolution is a classic sign of malignancy.
Even at this early stage, it's absolutely crucial to screen for any signs of metastatic disease. So I'd ask about things like new and persistent back pain, which could suggest bone mets, any abdominal swelling or jaundice for liver involvement. A new cough or shortness of breath could point to the lungs. And of course, I'd ask about those general constitutional symptoms like unexplained weight loss or night sweats.
And to round out the history, I need to understand the patient's risk profile. I'm going to ask about their lifetime sun exposure, especially any bad, blistering sunburns they had as a kid. Tanning bed use is another big one. I'd also need to know about any conditions or medications that might cause immunosuppression, any personal history of skin cancer, and really importantly, any family history of melanoma, especially in a first-degree relative.
Very thorough. And the physical examination?
My examination would start right at the lesion. I'd use a systematic approach, something like the ABCDEs. I'll note the exact site and measure its size. Then I'll look for A for asymmetry, B for an irregular border, C for any variation in color, D for a diameter over 6 millimeters, and E for any evolution or elevation. I'd also gently palpate it to feel its consistency and check if it's fixed to any deeper structures. But the exam doesn't stop there. I would then move on to palpate all the regional lymph node basins. For a lesion on the back, that means paying close attention to the axilla and the neck. And finally, a complete head-to-toe skin check is mandatory. I'd look over their entire skin surface, from the scalp to the soles of their feet, to make sure there aren't any other suspicious primary lesions or in-transit metastases.
Excellent. Your clinical suspicion is high. What is your next step to confirm the diagnosis?
Well, to get a definitive diagnosis, tissue is the issue, so the next step is a biopsy. The gold standard for most suspicious lesions is a full-thickness excisional biopsy, taking the entire mole with a narrow, maybe 2 millimeter margin of normal skin. This gives the pathologist the whole picture. Now, if the lesion is huge or on a cosmetically sensitive area like the face, an incisional or punch biopsy of the thickest part is an option. The one thing to absolutely avoid is a shave biopsy. That's a major pitfall because it won't give you the full depth of the lesion.
And getting that full depth is critical because it allows us to determine the Breslow thickness. This is, without a doubt, the single most important prognostic factor we have. It's a precise measurement, in millimeters, of how deep the tumor has invaded, and pretty much every decision we make from here on out, from surgical margins to further staging, is going to be based on this number.
The pathology report will also mention Clark's levels of invasion, which you can see here. Now, while Breslow thickness is what really drives our management, Clark's levels are still useful. They describe which anatomical layer of the skin the tumor has reached, adding another layer of detail to the histopathology report.
So while we wait for that crucial pathology report, I'd get some baseline blood work done. This is partly for preoperative assessment and partly for staging. I'd order a complete blood count, a coagulation profile, liver and renal function tests, and, very importantly, an LDH, or lactate dehydrogenase. An elevated LDH is an independent poor prognostic marker in melanoma.
Very good. The biopsy confirms a malignant melanoma with a Breslow thickness of 1.5 millimeters. How do you manage this patient now? Okay, the first and most important step is that this patient's case must be discussed in a multidisciplinary team meeting. With a 1.5 millimeter melanoma, a sentinel lymph node biopsy should be considered to stage the regional lymph nodes. This would be done at the same time as the definitive surgery, which is a wide local excision of the biopsy scar. And of course, all the tissue removed is sent for full histopathological analysis.
The margin for that wide local excision is determined directly by the Breslow thickness. These are the standard evidence-based guidelines we follow. For an in situ melanoma, a ½ centimeter margin is enough. For any tumor up to 2 millimeters thick, we take a 1 centimeter margin. And for anything thicker than 2 millimeters, a 2 centimeter margin is the standard of care.
So applying that directly to our patient with their 1.5 millimeter melanoma, the correct surgical treatment is a wide local excision with a 1 centimeter margin. In the operating room, I would mark that 1 centimeter radius around the biopsy scar and excise the skin and subcutaneous tissue all the way down to the deep fascia, but not including it.
The wide local excision and the sentinel lymph node biopsy are both negative for malignancy. This makes the patient stage IB. What is your long-term follow-up and surveillance plan?
Okay, follow-up is risk stratified based on their stage. For this patient, who is stage 1B, they will need a focused history and physical exam every 6 to 12 months for the first 5 years, and then it becomes an annual checkup for life. This exam will always focus on the surgical site, a check of the regional lymph nodes, and a full-body skin exam.
And finally, a huge part of long-term care is patient education. It's a partnership. I teach them how to do their own monthly self-exams of their skin and lymph nodes so they can spot any potential recurrence early. And I'd provide really comprehensive counseling on sun safety. We're talking sun avoidance during peak hours, wearing protective clothing, and of course the proper and regular use of a high SPF broad-spectrum sunscreen.
Excellent. You've outlined a safe, systematic, and evidence-based approach from initial presentation through to long-term surveillance. So to recap the absolute key points from this case, first, remember that tissue is the issue. You must get a proper biopsy. Second, staging is everything, and Breslow thickness is the king of staging. Third, melanoma management is a team sport. It requires a multidisciplinary approach. And lastly, don't ever underestimate the power of good surveillance and patient education for long-term success.
That concludes this station. Remember that a structured approach is your best friend in these scenarios. Early detection and systematic management are what save lives. Now, are you ready for the next case?